Hello friends, I will be presenting a topic on post-op care in reserve and LRS fixator. The post-op period begins from the application of the frame. It ends after the fixator removal. Frame application is the beginning, removal is the end of the post-op period. What you saw in the surgery shall you reap. So be careful in the every step you perform during the application of the Elizarov fixator. What ensures a good result is a good alignment, a stable fixator frame, good surgical techniques in terms of respecting soft tissues, pin site insertion through the safe zones, start and stop technique for drilling of shank pin and reservoir wires, and a good post-op care. We will be discussing this presentation under these heads: time periods, the pin site care, positioning rehabilitation physiotherapy, follow up, how to deal with the pain, and the fixator removal. Three time periods are important after the osteotomy, and first is latent period, second is phase of distraction, and third is consolidation phase. Latent phase is usually 7 to 10 days. It is lesser in children and longer in when there is a comminution at the while performing the osteotomy. The invasive technique has been used to do the osteotomy, and when there is an acute displacement of the fracture. Distraction, the DC nuts are usually recommended, which has got four sides, and every side is marked with the dots, as you can see. The flags are applied flush to those DC nuts. The nail polish is applied, which ensures us that one circle has been completed. There are few advantages of applying the flag flush to the nut. One is it gives you a rough idea that how much is the distraction has been happened since the beginning, and whether the all four rods are being distracted symmetrically. Rate is usually 1 millimeter per day. Rhythm is 4 times in a day. So 1/4 turn every 6 hourly. These things need to be noticed during the follow-up. The left sided is the first picture. As you can see on the right sided picture, the distance between the flag and the nut is symmetrical in all the four rods. So this ensures that uniform distraction has been done between the proximal and the middle ring. The compression needs to be done till you see radiological docking. It is advised to continue compression for 4 to 5 millimeter further. Arcing of the wire shows the adequate compression has been achieved. Distraction needs to be continued till the desired length is achieved. Consolidation phase is usually double the time of the distraction phase. If the distraction phase is for 2 months, then consolidation phase will be for almost 4 months. The fixator time is usually 1 month per centimeter. Pin site care, in which it is recommended to use a boiled and cooled water, sterile gauze pieces. No need of ointment, powder, or betadine solution. You can see the pin needs to be cleaned from all the sides, and if there are any scabs, they need to be taken off. This is a very important slide, how to dress a pin. These are few pictures of the infected pins. where you can see the crusting around the pin, or you can see redness around the pin. These are few pictures of clean pin tracks. You can assess the pin site in the X-rays as well. In these two pictures, we can see there is a good bond between the Chance pin and the bone. While in these pictures, you can see there is some lucency around the Chance screws. You can see here lucency around the Chance screw, which is indicative of pin side loosening. One need to observe, listen, and assess not only bone but also the muscles, nerves, joint, and mind of the patient. Assess clinically whether the patient is walking well, whether the joints are mobile, how is the pain, what is the distance or angle between the rings, is the fixator is stable, and the pin tracks. The mobility and the function needs to be checked at every follow-up. How is his range of motion? How is the function of quadriceps? The gait pattern, a touchdown pattern of gait is recommended, a step through gait pattern. And one needs to prescribe the necessary aids for the walking. Eventually, it is recommended to walk without any aid. You can see the X-ray is centered or focused on the regenerate area in this X-ray. As the bone is being transported for the distal tibial non-union, once the docking is achieved, one needs to focus the X-ray over the ankle or the ring near the ankle. So in this case, you can see the ring near the ankle can be seen as one single line in all the four views. That allows us to see the bone, whether it is healing or not. If there is any overlap, if there are double shadows, it is difficult to assess the union of the fracture. Assess the X-rays for bone gap, the quality of regenerate, how is the angular correction is being proceeded, and the deformities around bones and joint. These are the importance of assessing the serial X-rays. You can see the regenerate quality has improved on the picture in the right side. So one needs to be vigilant to observe these changes. The pillow has to be kept below the distal most ring, but not under the overall the fixator or leg. If the fixator pillow has been kept below the leg, you can note some flexion in the knee joint. If you keep the pillow below the distal most ring, then the knee will be kept in the extended position. The active movements are encouraged. Passive stretching, where you suspect any deformity. Early ambulation and weight bearing. Touchdown weight bearing to begin with, as tolerated is advised, and eventually it should be shifted to full weight bearing. The use of preventive orthosis and splints. Iliceral fixator is not painless. At the most, it's discomforting. The pain is preventable and manageable. The pain is because of three reasons. One is pain of distraction, which is more in the evening or in the night time, which can be managed with the help of ice packs, break up the distraction, regular breaks in the nut turning, and use of NSAIDs. If one is turning a nut 4 times in a day, we can divide those 4 into 8 times and eventually we can complete one full circle. The tension pain, which is due to the tenting of the skin or loss of the tension in the wire, and pain due to instability. The tenting of the skin can be managed by giving an incision around the convex area of the tent. Neutralization is done just before the removal of the fixator. The nuts are backed off by 2 to 3 mm so that to remove any compressive or destructive stress in the frame, and loading is encouraged after this. A month too late is always better than a day too early while removing the fixator. All the 3 cortices, at least 3 cortices needs to be well healed. The patient should have full function, and we perform this stress test before the fixator removal, where you can see the connecting rods are removed. We check whether the patient walks comfortably after removing those connecting rods. If this is the gait pattern, then it is okay to remove the fixator. So this X-ray shows the well-healed cortices. 3 cortices are very well healed. But if you observe, there is some wasting of the regenerate in this area. So in this type of situation, we can put an internal splint, like a TENS has been kept put in this case. This patient developed a fracture around the regenerate area, but it healed without any issues. These are steps while removal of the fixator. Loosen up the central bolts, detensioning of all the wires. Then wires needs to be cut. Shank pin needs to be removed. Clamshell removal of the frame. It is advised to use local anesthesia for olive wires, and general anesthesia is recommended in case of children. The take-home message is Winside care is utmost important. Be vigilant and take appropriate measures. A good rehabilitation ensures a good result. Thank you.